Today I'm going to be talking about nitrous oxide oxygen inhalation sedation, otherwise known as conscious sedation, otherwise known as relative analgesia, inhalation sedation. Nitrous is basically an altered state of consciousness. We are specifically talking about the Michigan nitrous oxide law. It was passed in 2004, and it allows dental hygienists to administer nitrous oxide to patients 18 years old and older under the direct supervision of a dentist. So it means a dentist has to be on the premises. A hygienist cannot administer more than 50% nitrous oxide. A dental assistant can monitor nitrous and oxygen, but they should not be administering or adjusting the nitrous. You sometimes see this in offices, but this is not accepted under the law. They are doing this can be legally. The dentist can be in there and he can adjust it, but the assistant can only monitor it, except to completely turn the nitrous off in an emergency situation where 100% oxygen is needed. So the history of nitrous oxide, we're always looking for a better pain reliever. In dentistry in particular, as we've talked about local anesthesia, we're always looking for the next best thing. Started out with cocaine, esters, amides, articaine. We went through that whole time frame. Now we're looking at nitrous oxide. So in the late 1700s, specifically 1772, Joseph Priestley discovers nitrous oxide and oxygen gases. They did a lot of experimenting between 71 and 77, but specifically the date, 1772, and Joseph Priestley discovering nitrous should be one you remember. Early 1800s, Humphrey Davy was the first to inhale pure nitrous oxide. He had diminished pain when he had a toothache, and I like to read this specifically because Davy became euphoric. He felt like laughing, said that the nitrous produced the most voluptuous sensation described as ideal existence with overwhelming joy. I can't imagine how much nitrous he had to have to make that statement. For the next 4 decades, into the 1800s, there was a lot of nitrous parties, evening entertainment, and reckless use of nitrous, as they found that this gas gave them this voluptuous feeling and ideal existence and overwhelming joy. Specifically, 1844 is another date that you should remember that nitrous was first used in dentistry. 1844, there was an exhibition showing the effects of nitrous. And in 1845, Horace Wells demonstrated the use of nitrous while extracting a tooth. Oxygen was added in 1868 to the use of nitrous inhalation sedation. Medical community has always been searching for pain relief options. Patients would commit suicide versus do an operation without pain control. So brute force, people were held down to operate on them. Alcohol, opium, tourniquets were all used. So nitrous was a welcome gas analgesia that was used for pain control and lessening of the pain. 20th century dentists are primary users of nitrous oxide inhalation sedation. We always use nitrous with oxygen. In the 50s and 60s is when the dental schools began teaching the techniques of nitrous and oxygen. And like I said, 2004 is when Michigan passed the law. Today it's used always with oxygen, remains very safe, and basically the best years of this sedation are now. So they've learned a lot about nitrous. Some advantages of nitrous, you guys should know these for testing purposes. Advantages of nitrous are the onset of action. It works fast. It gets into the system and it works fast. So the onset of action is quick. The ability that we have to titrate nitrous, to give the patient the amount that's needed to titrate, is a great advantage of nitrous. The time required for a recovery. I mean, we turn the nitrous off and the patient breathes 100% oxygen for 3 to 5 minutes after nitrous oxide, and they have a really fast recovery. they can drive right after. They don't need anybody extra to come with them to the appointment if they're going to have nitrous oxide. They can leave the appointment after they've been on that 100% oxygen for a couple minutes. They're recovered. A disadvantage, one of the main disadvantages to nitrous is the cost. The equipment and the whole setup of nitrous oxide in an office can be costly. So that's basically the biggest disadvantage. So when we're talking about nitrous, we're talking about the 4 A's. 4 A's being analgesia, anxiolytic, anesthesia, and amnesia. So for these 4 A's, the 4 properties of A's with nitrous, the analgesic effect is it reduces the intensity of pain. It doesn't eliminate pain, but it reduces the effects of pain. The anxiolytic is with minimal sedation, the anxiety level of the patient goes down. So non-pharmacological techniques, there's a relief of anxiety. And then anesthesia, there can be a partial or complete loss of sensation without a loss of consciousness. So it's a weak anesthesia, but there can be some partial loss of sensation. And then amnesia, patients can't recall the severity of the pain. One of the interesting things that I can recall from nitrous use over the years is there are so many children, which we as hygienists cannot do it on children. We're doing it on people 18 years of age and older. But when I was an assistant working with a dentist, a lot of children would have nitrous oxide. They were scared of getting the shot. Their parents would, prep them and, use all these big words, and they would be scared to death of the shot. And you would take the nitrous off at the end. They would breathe their 100% oxygen for 3 to 5 minutes. And you would take it off and you go, oh, the parent would go, oh, did you feel a shot? I didn't get a shot. They would have totally blocked out that, that level of pain just because it gives them an amnesia effect. So it's a form of conscious sedation using inhalation that has analgesic, anxiolytic, anesthesia, and amnesia properties, the 4 A's. It's conscious sedation, a minimally depressed level of consciousness where the patient maintains an airway and responds to verbal commands. If you're talking to them, they're talking back, sometimes saying kind of funny things. They'll get a warm, tingly feeling in their fingers and toes. They'll feel a little drowsy. They'll feel a little bit warm. That's pretty normal. A little throaty. The vital signs are normal and they remain unchanged when someone is on nitrous. So like we said before, conscious sedation using inhalation, and it's a colorless, odorless gas, only inorganic gas that is used to produce anesthesia in humans. Non-irritating, it's got a little bit of a sweet smell, but basically non-irritating, sweet smelling, very low smell, odorless, colorless gas that is the only inorganic gas used to produce anesthesia in humans. Stages of anesthesia are really important, and you should know for test purposes for board patients or for board purposes the stages of anesthesia. Stage 1, this is where your patient should be. Conscious sedation, ideal for nitrous and oxygen for dental use. The patient that you are seeing, the patient that you are administering nitrous oxide to should stay in stage 1. We do not want them in stage 2, which is slipping into delirium. If a patient is left unattended and the nitrous is high and they're breathing in if it's a little, and we'll get into the distribution or the giving nitrous in a little bit later. But if a patient's left unattended, they can slip into stage 2 delirium. The patient may become combative, overreactive, pupils may dilate. With us, as hygienists, we're never going to get them into stage 3 surgical anesthesia. It's very difficult for anybody to get them to stage 3 with nitrous oxide. Nitrous alone used, it can be an induction agent for general anesthesia, but nitrous alone can usually not get them to the stage 3 surgical anesthesia. And then stage 4 is respiratory paralysis and death. We don't want to be anywhere near there. So Hygienist, stage 1. Slipping into delirium, stage 2. Stage 3, we can't even get there with nitrous. Stage 4, we never ever want to be there because that's respiratory paralysis and death. You have to know those stages. Advantages. We talked about the onset being rapid, ability to titrate or give the patient the amount that's needed. That's a great, great advantage. The depth of sedation can be altered based on how much we give them, how much nitrous that we give to the patient. And the duration of action is variable. There are patients who will come in and they only want the nitrous on while they're getting the shot. The shot is what is making them very anxious, and they only want the nitrous on as they're getting, you know, their local anesthesia injection done. Not the shot, I'm not supposed to use that word. So when they're getting local anesthesia injection, they want it on then, and then we turn it to 100% oxygen, 3 to 5 minutes, take it off, and then we perform the rest of the procedure. The recovery is complete and it's pretty rapid. They can drive right away afterwards. The important thing is that when we're done with the titration of nitrous, giving them the nitrous, we give it to them slowly, move it up slowly till they are in that altered conscious state. And then we turn it off. We don't titrate it out. We just turn it off to oxygen, 100% oxygen. We do that for 3 to 5 minutes to make sure that the patient doesn't get what we call diffusion hypoxia, which we'll address in a few minutes. Dr. Nancy calls that the bad deal, diffusion hypoxia. So it's really important that at the end of terminating the nitrous oxide administration that we turn them to 100% oxygen. We're doing it in an outpatient setting. We used to have nitrous oxide available in clinic, and we would use it on clinical patients. Problem is we had one nitrous tank. Nitrous is expensive to use as a general, the equipment's expensive, the tank of nitrous is expensive, and patients would see that, and some that didn't officially needed it, just wanted it, just liked it, would want it, and they'd see their buddy down the way getting it, or, you know, another patient down the way. And it got to be a little bit more than we wanted to deal with as far as the clinical application using it on our patients in the clinic. No injections in some cases. When I was a kid, I've got fillings from when I was an early teenager, you know, the buccal pits on 30 and 19 and a couple of occlusals, and I never had any injections. That nitrous oxide relaxed me enough that they could do the procedures and do the small fillings with no injections, only the nitrous oxide. And it's safe. Disadvantages is the cost. The cost of equipment is pretty high. The cost of the gases is really high. There is some regulation as far as bringing the nitrous oxide gas to your office, to your place of employment, to your clinic. The FDA regulates the nitrous oxide industry, but DOT, Department of Transportation, oversees the transportation part of the nitrous oxide coming to your office or clinic. So FDA regulates the nitrous oxide industry as a whole. The DOT, Department of Transportation, oversees the transport of the nitrous, and all of that is added into the cost, you know, of the gas. The equipment's cumbersome. When we are using it in the clinic, you guys will see that we have a tank, and we have the blue nitrous tank. That's something you should know, star, star, star. The nitrous oxide tank is blue. The oxygen tank is green. You guys see the green oxygen tank sitting at the end of the clinic, and we need that there for emergency purposes. Green is oxygen, blue is nitrous oxide. And to have 2 tanks that we wheel out, or if we're in an office situation, there's 2 tanks. Some of them are as tall as I am. I mean, there's large tanks, and they have to be chained to the wall. They have to be kept in a secure location. So it's cumbersome to have somewhere like that where you have to bring those tanks to the patient, or where you have to keep them chained up, locked up, and have piping then piped into the rooms. Nitrous is not really potent, and sometimes the desired clinical effects may not always be achieved. I have a couple patients that I can recall giving them nitrous, and they would always say, you know, I can't feel it. You got to turn it up. You got to turn it up. You got to turn it up. Hygienists can only turn it up to the 50% mark, and after that, I had one patient that would say, well, I'm going to tell Dr. Pinckney on you if you don't turn it up. Well, I'll get him in here and you can tell him, because I'm only going to do what my license allows me to do. Personnel must be trained. So as hygienists, we are here and we're learning about nitrous oxide, and we're going to learn a lot about the relative contraindications and the absolute contraindications, patients who we should or shouldn't use nitrous on, and what the amounts are that we should use and what we should look for. If a patient is going into stage 2 delirium, we want them in stage 1 for the ideal anesthesia. And we've got to be trained on that. An assistant who is working with the doctor has not had that same training. They haven't had any training except for watching the dentist and maybe some comments from the dentist as far as the stage or number that they want the patient to be at. And there are harmful effects, which we'll talk about a little bit later. There's harmful long-term effects. There's harmful effects to certain patients. So indications for use of nitrous. One thing is that I wanted to mention about the equipment before we go on is if you don't have any oxygen, nitrous cannot be used. It has to be used in conjunction with oxygen. So you can't ever give someone full nitrous. Oxygen and nitrous have to go together. So if you run low on oxygen, you're not using nitrous. And there has to be somebody in the office that monitors the supply and reorders in time. It's not something that you can necessarily get the next day. You have to monitor that and know when you're going to be out of either the oxygen or the nitrous. It's great for managing fear and anxiety. That's the #1 thing that nitrous is used for very nervous patients. It's a great thing to discuss with them as an option. Kind of makes, when I'm describing it to a patient, I tell them, you know, you're able to feel and you're able to talk. It just, you feel what we're doing, but you don't care as much. It's like you've had a couple of glasses of wine. Some people say, oh, I don't drink. Well, it feels like this is what it feels like when you do have a couple of glasses of wine. One thing that typically contributes to cardiovascular risk is the lack of oxygen. So you're getting nitrous and oxygen. So they're reducing anxiety and you're getting the oxygen flow that's needed. So you may also be able to reduce the risk of an asthma attack in patients with asthma if you reduce the stress level. So we still want to be very aware of any of our medically compromised patients, but sometimes just because they're medically compromised doesn't mean that it's an absolute contraindication. It can be a relative contraindication where we have to pay more attention to them. It doesn't affect the cardiovascular system negatively. Yay, this is something that we can use. In most cases, the blood pressure stays about the same. Might be a little bit lower because the patient relaxes and they're not as anxious. So in that case, it's an advantage. May reduce the gag effect. Nitrous oxide and oxygen sedation may reduce the gag reflex. And I have seen this done in patients who have a hard time with x-rays. If you're able to get them to relax, and some people are anxious just to, they know that they're going to gag and they have that anxiety, and you barely have the x-ray in their mouth and they're already gagging. You're like, I haven't even touched you. If you give them that nitrous, they still know you're doing it, but they just are not as aware and hyper aware, I would say, of that. Great thing with nitrous, there's no known allergies. There's some contraindications, which we're going to talk about over the next couple minutes. Some absolute, some relative, but no known allergies to nitrous. The absolute contraindications are all related to lungs. So pneumothorax are patients with cystic fibrosis or COPD, which is the emphysema and bronchitis together, and people that have had cancer treatments for Hodgkin's lymphoma that may have caused fibrosis of the lungs with the bleomycin sulfate. These are the people who would be absolute contraindications. So COPD, cystic fibrosis. Now, I'm telling you that these are absolute contraindications, and in the book it says they're absolute contraindications, but the CDCA says there's no known absolute contraindications. These are the ones that we would list as that, but keep in mind if you're using this in a case study type question, you know, on the regular boards, or if they're asking you more for you've really got to think about the question and look at how the question is worded to see if you would answer that these are absolute contraindications. COPD, emphysema and bronchitis together equals COPD. The patient's going to respond to the oxygen as the stimulus to breathe rather than the CO2. If they're giving the oxygen and nitrous, then they could lose some of that stimulus to breathe. That's important. So that's why COPD is on the absolute contraindication. These are patients that we see all the time. We see patients with COPD every day in clinic. So this is one that you really have to pay attention to. Cystic fibrosis, they have that excess mucus production because of the glands secreting improperly. So they're going to have not a lot of airflow going anyways. And upper respiratory infections. Patients might not be able to breathe. They're going to have a nasal hood over their nose so that they can breathe the nitrous in and out. Patient may not be able to breathe in the gases. The rubber goods, the inhalation devices might get contaminated. This is a relative contraindication because you've got to use your best judgment. There are the hoods are typically autoclaved, so they go through and they're sterilized, or they're disposable. So that might not be anything that you have to worry about as far as the rubber goods being contaminated. If they can't breathe through the nose, then it's not a great option. They might not be able to breathe in. If they have a deviated septum or enlarged tonsils or adenoids, they also might not be able to breathe in properly. So you're going to have to take a look at that as a relative contraindication. Anybody with TB or AIDS, when we use the disposable system and the nasal hood, we want to really watch cross-contamination. So depending on the system you have, and if it's disposable, if it is not disposable, if you have an office where you're just wiping things down, which of course we know is not the standard of care, but it could happen and you could see it, that would be a relative contraindication to using nitrous oxide on somebody with TB or AIDS or HIV. And then epilepsy. So patients with epilepsy, we've got to think about them being more prone to hypoxia, low oxygen levels. They need to be monitored more closely, and the use of nitrous could actually help because we're reducing their anxiety, which anxiety could bring on a seizure. And if they're able to relax with the nitrous oxide, then that could be a good thing. So relative contraindication because of the being prone to hypoxia. But if they're very anxious, then that could cause a seizure. With patients with personality disorders, compulsive patients, claustrophobic patients, children with disruptive behavior, even though we don't see children as hygienists in Michigan, or patients that are receiving psychiatric medications, nitrous oxide could make it worse, particularly with claustrophobic patients, because you've got this hood over your nose and you've got your hoses that connect this too. So it really makes a patient who has claustrophobic feelings anyways, it really makes them feel more claustrophobic. Somebody who has had a stroke, they may be more prone to hypoxia. They need to be monitored very closely. So it's a relative contraindication because of the monitoring. It's an absolute contraindication for anybody who is an abuser of nitrous oxide or has recently had a pneumonoencephalogram. I don't know how you would know this except asking good questions. If you know that they have had a stroke, ask better questions and maybe even do a medical consult to make sure that you're not giving them nitrous oxide in a case where They're low oxygen anyways, and you're going to diminish that oxygen capacity. For pregnancy, nitrous oxide does cross the placental barrier. Absolute contraindication to not use in the first trimester. So in the first trimester, no using nitrous. There are times when a medical doctor would possibly use it during delivery. It's all up to the MD, and it's best to leave that decision up to the MD. When we talk about pregnant patients and that it could be used in the third trimester, close to birth because the baby is fully formed, we still want to make that decision with an MD. Recent ophthalmic surgery. Certain gases can increase the pressure in the eye, and therefore nitrous oxide would be an absolute contraindication. So recent eye surgery, the pressure in the eye, we know glaucoma is one where we've got to watch with local anesthesia. Recent ophthalmic surgery is one we have to watch with nitrous as well because of the increase in pressure, absolute contraindication. For any contact lens wearers, we want the patient to remove contacts because it can dry the contacts out. When you guys are doing your nitrous experience, we're going to have anyone who's wearing contacts remove their contacts. Another one, let me go back real quick. Another one that you wouldn't really think of is if somebody is having bowel obstruction or bowel discomfort. There are air spaces within the bowels, and when somebody is using nitrous, the air spaces are displaced by nitrous and it can cause some bloating. So if you have somebody who you know has a history of bowel obstruction, bowel discomfort, they might be a person that it is a relative contraindication to use nitrous. Nitrous will potentiate the effects of any depressants. So you want to take note when somebody is on depressants, central nervous system depressants. So alcohol, opiates, marijuana, sedative drugs, you want to, it increases the effects of those other drugs. So it increases the depressant effect of those other drugs. So it would be a relative contraindication. And there are some patients who just don't want nitrous. You can give them that option because you know that they're anxious and they don't want it for whatever reason. Now we've got to think about the anatomy of the respiratory system. And I'm going to tell you a little bit about nitrous here, just in general. We're going to go into this further. But nitrous oxide is prepared commercially by heating ammonium nitrate crystals. And this is in your packet right before the anatomy of the respiratory system. Nitrous oxide is prepared commercially by heating ammonium nitrate crystals, leading to decomposition to nitrous and water. It is marketed as liquid under pressure stored in cylinders. An interesting phenomenon occurs as nitrous oxide exits the cylinder. The walls of the cylinder become cold and some frost can even be found around the exit portals of the nitrous tank. This happens because liquid nitrous oxide requires heat to vaporize into the gaseous state. This heat is obtained from the walls of the cylinder and from surrounding air, and that's why the cylinder gets colder. So nitrous oxide in our blue tank would be held at 750 pressures per square inch. 750 nitrous oxide in the blue tank. When it's full, it's 95% liquid and 5% vapor. The gauge won't decrease from that 750 pounds of pressure until the tanks are about 20% full. So you really want to monitor that, and when it gets to 20%, you're ordering your next tank. Oxygen is green and it has 2,000 psi, and it's an accurate pressure gauge. So you're going to watch that go down in increments as it goes down. When we have our nitrous, it's the non-irritating, sweet-smelling, colorless gas, only inorganic gas used to produce anesthesia in humans. It's going to be inhaled into the lungs. And a lot of really important things for boards you need to know about the lungs. So in general, we've got to look at the anatomy of the alveoli. And we've got to think about all of the parts, organs of the respiratory system. We're going to think about the nose, the nasal cavity, the sinus, the pharynx, the larynx, the trachea, the bronchial tree, and the lungs. And you can see this is kind of a picture and overview of all of those. One thing we want to remember is the nasopharynx is the top area, the nose. Then we have the oropharynx, which is the back of the mouth going down into the larynx area. So we want to talk about those as the whole pharynx, the nasopharynx, oropharynx, laryngopharynx, in that order, right above the larynx. Then we've got the alveoli. The alveoli is where gas exchange takes place in the lungs. Each alveoli is surrounded by a capillary network, and there's rapid onset from nitrous oxide being breathed into the alveoli due to the high vascularity of the area around the alveoli, those capillary networks. It's very vascular. Now, upon inspiration, there's a higher gas level in the alveoli, and that higher nitrous oxide gas level is going to push into the blood on inspiration. When you're done, when you're going to expire, when you're going to exhale, then there's a higher nitrous oxide level in the blood, which is going to push into the lungs for expiration once the oxygen is turned on to get the oxygen out. So there's a concentration effect, which we'll talk about a little bit more in a minute, that occurs in the alveoli. Where does the exchange of blood and air take place? In the alveoli. Rapid onset due to the high vascularity, rapid onset of that concentration of nitrous pushing its way from the alveoli, higher concentration into the blood, lower concentration on inspiration, and then going the other way when we've turned on oxygen. Really, really important, the mechanics of respiration. Primary mechanics of respiration are the diaphragm and the intercostals. The diaphragm is going to contract, move down, creating a negative pressure. The diaphragm is going to contract when you breathe the nitrous oxide in. It's going to contract, move down, create negative pressure. The intercostals are lifting, rising up, making the chest expand. And this is in general, I mean, this happens obviously when we're breathing in nitrous oxide, but just breathing in general. The diaphragm contracts, moves down, creates negative pressure. The intercostals lift the ribs up and the chest expands. And then we've got a lot of abdominals, scalenes, sternocleidomastoid, and some back muscles that are accessory that help with the breathing, but the main ones are the diaphragm, contracting, moving down, creating negative pressure, and the intercostals, lifting the ribs up and the chest expanding. Star, 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 ding, ding, ding. At rest, the pressure in the lungs is equal to the atmospheric pressure of 760 millimeters of mercury. So at rest, the pressure in our lungs is equal to the atmospheric pressure of 760 millimeters of mercury. Active inspiration, so breathing in, is primarily the diaphragm and the external intercostals, assisted by the scalenes, the sternocleidomastoid, the abdominals, and some back muscles. So physiology of the respiratory system. Breathing is automatically controlled by the pons and medulla oblongata of the brain. This is the respiratory center. It's automatically controlled by the pons and medulla oblongata of the brain, the respiratory center. It's voluntarily controlled by the cerebral cortex. So automatically controlled by the pons and medulla oblongata, the respiratory center, star, 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 voluntarily by the cerebral cortex. The tidal volume is the amount of air, amount of gas breathed into the lungs. It's the capacity of the lungs. Tidal flow, so let's go back for just a minute. Tidal flow is just regular movement of air, ebb and flow. That's the tidal flow. Tidal volume is the amount of air, inspiration plus expiration during one normal breath. The amount of air, the inspiration and expiration during one normal breath. So this is how much can be inspired into the lungs, like the capacity of the lungs, the total volume of the lungs. Men generally are going to have a larger tidal volume, up to 25% greater volume than women. Larger chest cavities holds more air for the men, up to 25% greater volume. As a general rule for an adult will have 500 milliliters of tidal volume. We need to know some of the normal numbers as far as respirations is 12 to 20 respirations per minute. Let's see, another one. Sorry, I've got a couple notes here. I'll tell you the other ones in a minute. Respirations of 12 to 20. So adult has a 500 milliliter tidal volume times 12 to 20 respirations per minute will give an adult a 6 to 8 liter tidal volume average liters per minute for an adult. So 6 to 8 liters for an adult and 3 to 4 liters per child. And we'll talk about that again in a minute. So, and I'll go over this during our lecture in class, but 500 milliliter tidal volume times 12 to 20 respirations per minute gives us 6 to 8 liters for adult. 1 liter equals 1,000 milliliters. So if we're doing the math, 3 to 4 liters for child, you need to remember those numbers. 3 to 4 liter tidal volume for a child, 6 to 8 liter for an adult. So the minute volume, the amount of gas that's brought into the lungs each minute, it's figured by multiplying the tidal volume, the 500 milliliters for adult, by the 12 to 20 respirations per minute. 6 to 7, I told you 6 to 8, 6 to 7 liters per minute for an adult, 3 to 4 liters per minute for a child. The nice thing about this ventilation, and we'll get into this more as we get into the equipment that we use for nitrous, is the ability to titrate the drug. The ability to titrate the nitrous to the patient and administer only what is necessary is a really big advantage of nitrous oxide. We can titrate the drug, the nitrous, to the patient with the ability to administer only what is necessary for the patient. There are different levels of tidal volume. In general, we're talking about 6 to 7, 6 to 8 liters per minute for an adult, but we're going to use the amount of nitrous that is appropriate and achieves our conscious altered state for that patient. We're going the wrong way. Go the other way. All right, pharmacology of nitrous. So I talked about nitrous being prepared by heating ammonium nitrate crystals. It's stored as a liquid under pressure in a cylinder. As the gas exits the cylinder, it gets cold. We've got our blue cylinder, and it will be like ice cold to the touch. It's the sweet, non-irritating, colorless gas, only inorganic gas to produce anesthesia in humans. The minimum alveolar concentration is the minimum concentration of the drug needed to prevent movement in 50% of subjects responding to a surgical incision. In other words, 50% of subjects will get movement of nitrous to the brain from 104 to 105% MAC, minimum alveolar concentration of nitrous. Nitrous isn't very potent, so it needs that 104, 105% minimum alveolar concentration to work. It's not very potent. It's the least potent of inhalation anesthetics. If you're making flashcards, you'll have least potent inhalation, and nitrous oxide is 104 to 105% minimum alveolar concentration. Talking about gas solubility. We've got to talk about the atmospheric air. Atmospheric air has 79.02% nitrogen, 20.94% oxygen, 0.04% carbon dioxide. These gases combined produce pressure of 760 millimeters of mercury at sea level. Gases move from a higher to a lower pressure to equalize. So we've got to keep those facts in mind. Atmospheric air, 79.02% nitrogen, 20.94% oxygen, 0.04% carbon dioxide. Star, star, star. These gases combined produce pressure of 760 millimeters of mercury at sea level. Gases move from higher to lower pressure to equalize. Nitrous oxide replaces nitrogen. Nitrous oxide replaces nitrogen. It doesn't replace all 79% of nitrogen, but it replaces some nitrogen. So we've got water vapor that makes up part of the gas pressure in the alveoli. And then the other gases that compose the gas in the alveoli that exert partial pressures are the oxygen, the carbon dioxide, and the nitrogen, which is the combination of atmospheric air. The speed at which they diffuse across the membranes depends on the partial pressures. Gas moves from a higher to a lower pressure. That's why on the way in, it will move from higher pressure in the alveoli into the bloodstream, which then takes it to the brain for effect. And it will move from the bloodstream to the alveoli when it's 100% oxygen at the end of the procedure. So here's the example. Partial pressure of oxygen in the alveoli is 103 millimeters. Capillary pressure is 40. Which way is the oxygen going to go? It's going to go from the alveoli with the 103 millimeters of mercury pressure to the capillary. Am I going the wrong way again? Sorry. All right, at the end of the procedure, using nitrous, patients no longer breathing the nitrous, they have 100% oxygen. Will the partial pressure of nitrous be higher in the blood or the alveoli? In the blood, and it's going to go to the alveoli or alveolus. Which way will the nitrous go? From blood. Higher pressure in the blood, it's going to the alveolus to be exhaled. So nitrous is relatively insoluble. Peak action is 3 to 5 minutes. When you have it titrated correctly, 3 to 5 minutes is when the peak action occurs. So blood gas partition coefficient is the difference between the pressure of the nitrous and the pressure in the blood. So we just talked about how if there was more in the blood, it goes to the lungs or vice versa. The more, and star, the more soluble a drug is, the larger quantity of the drug is needed to reach the brain, the longer it takes before clinical effects are seen. So highly soluble is going to diffuse quickly into the blood. It's going to be longer before clinical actions are evident. A large amount of the drug is needed to move the agent to the brain. If it's relatively insoluble, concentration in the alveoli will be high and the onset of action is rapid. So nitrous is relatively insoluble. It has a high concentration in the alveoli. The onset of action is rapid for nitrous. You do need to know, and I'm sure that there's a quiz or a test question, the fact that the more soluble a drug is, the larger quantity of the drug is needed to reach the brain and the longer it takes before clinical effects are seen. Nitrous is great because it's relatively insoluble, concentration's high, onset's rapid. We don't want a more soluble drug that needs a larger quantity that takes longer to get to the brain. We want something that needs a low quantity, works fast, and onset is fast. Two phenomenons occur when there is a rapid uptake of gas. These two you really need to know about. Star, you're guaranteed to get questions on the quizzes, final, and board exam. So initially, and we're talking about nitrous, we're talking about nitrous oxide. Concentration effect. Higher the concentration of gas inhaled, the more rapidly it goes from the alveoli into the blood. Higher concentration, higher, and let's go back for a second. I thought I had one more slide. When delivering gas at a high concentration, the volume of inspired gas is high, arterial pressure is increased. So if it's high on inspiration, higher gas pressure in the alveoli pushes nitrous into the blood. On expiration, higher nitrous in the blood pushes it into the alveoli. Initially, when nitrous was first used, it was used to vacuum halothane into the lungs, into the bloodstream for faster general anesthesia, which we'll talk about this in a minute. But the concentration effect, they found that nitrous by itself, with just the higher concentration in the alveoli, it diffused quickly into the bloodstream because of the higher concentration in the alveoli. That's the concentration effect. Higher concentration in the alveoli pushes it into the bloodstream. Second gas effect is what I was talking about with the halothane. So it's a difference between the partial pressure of the gas, the nitrous, and the blood. Oh, I'm going back the other way, sorry. Higher concentration of gas inhaled, the more that it's going to go in. Second gas. This occurs when a second gas is administered along with the nitrous. So this is where the halothane comes in. The second gas is actually vacuumed into the lungs, and its uptake will be greater than if it was used alone. So the nitrous is insoluble, goes in fairly quickly, and then halothane goes in right back behind it. That is one of the inhalation gases that they use for general anesthesia. So they'll start out with nitrous and it sucks the halothane in. That's the second gas effect. It makes the second gas go in a lot faster than if that was going in without. Tissues with greater blood flow are going to receive more nitrous oxide. Others are going to absorb only small amounts. So if you have your brain, your kidneys, your liver, all of the more perfused organs are going to absorb and receive more blood flow, more nitrous. Others are only going to absorb a small amount. Most nitrous is exhaled through the lungs, 99%. Some nitrous is biotransformed by bacteria in the bowel and the GI tract, but 99% of the nitrous is exhaled by the lungs. Here's our diffusion hypoxia. So after nitrous oxide flow is terminated, nitrous diffuses out of the blood and into the alveoli rapidly because of the pressure. So there's more in the blood, less in the alveoli, so it goes out quickly. If the patient breathes atmospheric air, diffusion hypoxia can occur. This is the bad deal that Dr. Nancy talks about. The patient must breathe 100% oxygen for 3 to 5 minutes after the nitrous oxide terminates. I had a friend who came in. He likes to have nitrous when he gets his teeth cleaned, just because he likes it or offers it, makes him relax a little bit. We're always kind of in a hurry to get him done within the hour because he's got some periodontal concerns, and he had a conference call. And he says, you know, I got to be out of here by 2 o'clock for my conference call. And we were getting close to the end of the appointment, and nitrous, you know, we were done with the nitrous, and I kind of looked over at him, and he's already got his mask. I turned it on to 100% oxygen. He's already got his mask off. And I'm like, whoa, whoa, whoa. He's like, no, I'm fine, I'm fine. I'm like, whoa, this is a bad deal. And he went to his car, did his conference call, and he said, oh my God, I was totally out of it. I felt like they had to have known, like, what the heck was going on with you? Have you been at the bar drinking for lunch or what? He says, I felt like I was totally out of it. Well, yes, you were totally out of it because of the diffusion hypoxia. And in fact, let me get to this page here. So when you breathe atmospheric air too soon, you have the nitrous is exhaled and carbon dioxide, and it decreases your stimulus to breathe. So it really is a bad deal. Patient breathes atmospheric air, lungs become filled with nitrogen, oxygen, carbon dioxide, water vapor, and nitrous. Large amounts of nitrous are exhaled because of the concentration effect in reverse. More carbon dioxide exists now than usual, reduces stimuli for breathing. So less oxygen, hypoxia. So he was feeling diffusion hypoxia on his conference call. He told me about that the next day, you know, because we're friends. And then I said, well, you're the one who wanted to rip it off. I told you had to sit there for a couple minutes. And he said, well, I thought I was fine. No, I'll tell you when you're fine. 3 to 5 minutes breathing 100% oxygen so you don't get diffusion hypoxia. Headache, nausea, lethargic feeling. Routine administration of 100% oxygen for 3 to 5 minutes following the administration of nitrous oxide oxygen inhalation. When I am finished with a patient, typically I will switch them to 100% oxygen, and then I'll go writing the notes, making their next appointment, that kind of thing, just all my busy work. All right, so armamentarium for the use of nitrous oxide, oxygen, and inhalation sedation. I'm going to start with another video because this is kind of getting a little long, and I want you guys to be able to watch it and get all the notes and not get too bored hearing me. So, good job.